Hello, everybody. Welcome back. Today we are talking about when to call for help. This is one of those conversations that people are more than likely going to get their panties in a wad about. However, I want to, have a clarification up front. Number one, always follow your local protocols, policies, and procedures. If you haven't noticed, this show and everything attached to it is opinion. And yes, obviously, we do our best to provide facts and to base our opinions on facts. But nonetheless, these are our opinions. Always be smart, follow your protocols, policies, and procedures. But here's things for us to think about, some mindsets for us to consider. And hopefully, these are kinds of mindsets that, when applied appropriately, can be used to influence policy and procedure, hopefully. But kind of dealing more with just common sense things, common sense mindsets to have, so that you don't end up in a bad spot and your patients don't end up in a bad spot either. So, in general, it's better to have help and not need it than to need it and not have it. And I have told people this all the time because, like I've mentioned before, I work in kind of a tiered response system where I respond as a solo paramedic to usually just BLS transport trucks. And I get called for a variety of reasons. Usually, if I'm sent out there, there's a reason for it. Or if the crew calls me, there's a reason for it. But there's also times where crews will call, either they'll call me on my personal phone, or they will ask for me to respond to the scene just for second opinion, an additional set of eyes, so on and so forth. And I tell them all the time, I have no problem with that. I would much rather you call me out here and us have a reasonable, rational, clinical discussion about it, and both of us walk away educated and feeling good about the situation. I'd much rather have that than you not call me and something bad happen, especially to the patient. That's not fair to anybody. So, in general, that's my attitude towards it. And it's unfortunate that so many crews, not as much anymore, thankfully, because they've gotten used to me, but there were so many times where crews would be like, oh my God, I'm so glad it's you. You're not going to yell at us or treat us like shit. We shouldn't have to be in that position. So those of you who treat people like that for calling you out, even if you know that you aren't going to need to transport it, don't be a douche. Educate people. If you build a relationship with them, they will trust your word more when you tell them, hey, I'm comfortable BLSing this to you, and here's why. So, that being said, yes, it is important to have help available, to have appropriate resources to manage a patient, even if you end up not needing all of it, than to need it and not have it. However, it's also crucial to not be excessive tying up resources when it's not clinically necessary, and I have to put that caveat in there. The determination of what resources you need should be driven by clinical decision making. Translation: do what's in the best interest of the patient. If the patient needs to be flown, cool, fly them out. If the patient needs to go to a cardiac center, cool, take them there. If you have a feeling that something could go wrong a particular way, and you know that they would be better off at whatever specialty hospital versus a Band-Aid station down the road, cool, take them there. That should be what drives our thinking on these things. And I understand that there's, insurance considerations, and, if you bypass X number of hospitals that are, equally capable, then insurance is going to pay for it and all of that stuff. There's so many different things, and just varies service by service and what part of the country you're in and all of this. But it's important to make your decisions for resources, for destination, for anything, whether you ALS or BLS something, based on clinical necessity. Because, sure, there's the argument that says, well, they have toe pain. They could possibly have a STEMI. Okay, yes, in Fantasyland, anything is fucking possible. If we lived that way, we would never BLS anything we would fly out everything just because there's a possibility that something could go wrong. This is where, again, it is nuanced. It's very, very nuanced. You need to make the best decision for the patient based on their presentation, their history, all of the events leading up to you coming to them. All of that plays into it. So you have to use your head. You have to engage that noggin a little bit. Say, okay, yes, I understand that anything is possible, but what's reasonably possible? What makes sense clinically right now? And part of this too is knowing what you can competently handle. Notice I didn't say confidently. Now, confidence is important. It is a part of competence. However, I know plenty of people who are confident they can handle something that have no business writing the call. I have seen medics give their EMT partners this false sense of confidence that they cowboy writing these calls they really have no business writing. And that's not an insult to the EMT. That's an insult to the paramedic, who is so lazy and sloppy and has gaslit their EMT to the point where the EMT feels like it's appropriate for them to write calls that they have absolutely no business fucking writing. None. But another equal problem is when you have paramedics who are calling for ALS backup just because it's a chest pain call, just because it's the shortness of breath call, for no other reason than it fits into that category. I've seen this. It happens. And I'm like, if you can't handle that, you don't need to be doing this job, because you have a card in your pocket that says you are capable to be lead provider on these kinds of calls. You have that ability. Why do you not exercise that capability? If you weren't taught properly, you need to go learn. If you don't have the confidence, you need to figure it out. If you just don't know, we have a problem. And I run into this too. So let's pick apart the whole discussion of flight. I came under a little bit of fire, not a lot. It wasn't really that bad. Most people understood the point that I was trying to make, but I did a video on TikTok not that long ago that was addressing the flight flexing, how they're just like, I flew out all this and I flew out that, and I'm listening to them describe the patient. I'm like, but why couldn't you take that? You could have rendered all of the care that patient needed without delay, without any issues. Sure, maybe you had a slightly longer transport time, possibly, but everybody loves to compare. Oh, well, it's this far by ground, but it's only this far flight time. Okay, cool your jets a little bit. One, that is not the only amount of time that you need to consider when it comes to flight. They have their pre-flight checks. They have to start up the helicopter. They have to do all of these things, all of these steps. And then, it takes them a second to get down. It takes them a second to unload their stuff and come over to where you are, because usually an LZ is not in a convenient location. Not always. And then they still have to do a patient assessment, which is appropriate. I'm not shitting on that. Everything that I've described is exactly what they should be doing. 110%. They should be doing those things. They should be safe. They should be following protocol. 110%. Do all of the things that you need to do to safely execute that call. But all of that takes time. And then, once they do their assessment, they make the decision if they're going to RSI. Well, they're not going to RSI in the back of a helicopter if they don't have to, so they're going to go ahead and do it right then. They're going to do all these things. And if that's what your patient needs, okay. But you just need to think through all of these little segments of time that add up. I'll use as an example, and yes, this is highly anecdotal. And I'm not using it to say this is a universal rule, but this provides some perspective. There was one time I was on scene. I was roughly, I think from right there, I was a good 45 minutes, almost an hour from the pediatric trauma center, which is where we needed to go. Well, as I'm loading this patient up, I hear helicopter and I know which one it is. Well, one, I mean, it's close enough I can see, but I know what call they're going to because it's only, I mean, not, I don't even think it was 10 miles from where I was. And so I hear them and see them as I'm loading up my patient. Now, flight time from there would have been maybe 10, at most 15 minutes from where that helicopter was going to. The flight time from there to the trauma center that I was going to, I want to say it was like 10, 15 minutes. I don't know the exact number off the top of my head. I know just a guesstimation. So we get the patient loaded up. We start hauling ass. It's a solid 45 minutes running emergent. We beat the helicopter there. That's just an example of saying it's not just about flight time. There's a lot of other factors to consider. And in no way is that meant to be disparaging of that crew. I was not on scene with the call. I don't know what all, at least I don't remember what all was going on. I never followed up. I didn't know all of that. But point being, just the simple fact that you call a helicopter and they are able to fly quickly, that doesn't account for all of the other time that's going to be spent on that call. So just think about it. Think through it. Obviously, if there's a long distance to the appropriate specialty center that is not feasible to do by ground, okay, cool, fly them out. Around here, as I mentioned in the video, at least I'm pretty sure I did, I had to redo that video a couple of times because I didn't like it because it's such a nuanced conversation. But anyway, around here, if you have any significant burns at all, they need to be flown to Augusta. We don't have a burn center up here. You literally have to fly them out of state. Cool. Problem solved. But we do have a lot of trauma centers close by. Now, if I have an extended extrication time, sure, it makes sense. Especially if you auto-launched a helicopter, you've got an extrication time. It makes sense to have the helicopter because that extrication time is eating away at those kind of hidden delays that you encounter with a helicopter, so that ideally you're finishing extrication, the flight crew's there, they've already done assessment, you've transferred care, boom, 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 they're off and gone and done. Awesome, perfect. But if you have a patient that is literally just laying on the road that you can scoop up and start transporting, if you're an hour away from the facility, you might as well just keep going, because the delays that from activating a helicopter from that moment to intercept to transferring care and all of these logistics, you just should have taken them. Like you'd go ahead and get there. Personally, here's my thought too with helicopter, and maybe I'm sure there's counter arguments to this, and I can appreciate that. And obviously it depends on the kinds of helicopters you're dealing with too, just fair. But in general, in most medevac helicopters, at least around here that I've ever been around, if that patient goes into cardiac arrest, that crew is going to have to land that helicopter to manage that patient, to manage them completely. There's not a lot of room in those helicopters. Sure, there's some that are able to, have things pre-set up and they can manage that arrest just fine. But if they code, then it's a whole other shit show. Whereas, let's say taking them by ground, it's a few minutes longer, 10, 15 minutes longer. But if that STEMI patient codes, you're right there, your partner's right there, you can have help there on scene in no time, stabilize, continue transport, boom, done. Now this is one that's very, very, very touchy, because this is highly dependent on what resources are available in your area. So I'm going to speak in the context of where I work in South Carolina. We have comprehensive stroke facility that can take patients and have full neurological recovery up to 24 hours after onset, like full neurological recovery. When you have that much time to play with, if you're there in the first hour of onset, cool. You can take them to that facility by ground. It's within an hour of most counties in this part of the state. You can get there quickly. Take them. And how often have you had strokes? more so hemorrhagic strokes, but it's entirely possible with an ischemic or thrombolytic stroke. How many times have you had them decompensate like that? I've had plenty of strokes that were walkie-talkie, and then 5 minutes later they're not breathing. All right, that's not fair to put that on the helicopter crew midair. That's not fair for them. That's not fair for the patient. There's so much variety to the kinds of situations you can be in. There's so much complexity. There's so many ifs, ands, and buts. But ultimately, you need to make the decision that's in the best interest of the patient. And make the decision that's going to have the smallest delay possible with care overall. So just take the time to think through all of those, as many of those variables as you can. Be intimately familiar with the offerings around you, the facilities. Don't just blindly pick a hospital and say, "Oh yeah, we'll just go there." Well, no, because there's plenty of times where critical patients are dropped off at a hospital around here that doesn't have the definitive care that patient needs, and they end up sitting there for hours. That's not responsible. So know the capabilities of the facilities around you. And if you don't know, call them, ask them, "Hey, can you please clarify whether or not you're able to take this? Or can you please clarify your rating on this or your classification on this?" Okay, cool. Thank you. Then you can make an informed decision. But you have to go through that process. Now, I know I kind of beat the drum on flight a little heavy right there, because that was kind of the source of some controversy lately, and that wasn't my intent. My intent was to address the people that it's a flex for them to fly. "Oh, I flew this out. I flew that out. Oh, look at me. This was so cool and so exciting." Okay, it's not. They're an ambulance with wings. It's an ambulance with wings. Cool. Sometimes it has more capabilities. Around here, most of the capabilities that a helicopter has are available on the ground. We have a service around here that is not strictly a 911 service. They have 911 divisions, but they have blood. They have all of the capabilities, including Crike. Okay, cool. Like, I can intercept with them. I don't need a helicopter for that kind of thing. I have access to that through other means. Not everybody's in that kind of situation. So make the decision based on what your patient needs. Now, outside of helicopter, I am one that I don't call for help if I don't need it. And that some people can say that's cocky. It's not meant to be cocky. I personally am very comfortable knowing what I can and can't handle, and knowing when I'm going to be getting out of my depth and versus when I can handle it all. So I don't like to call for backup very often. It's very rare that I'll call for backup outside of, say, a cardiac arrest, a multi-patient trauma. Like, there's obvious exceptions, but for the most part, I don't call for backup unless there's really shit hitting the fan. And that's not me trying to be arrogant. That's the way I've been my whole career, because I was used to working in rural areas where you didn't have lots of help. You had to pony up and actually be confident in your skills. So that's what I advocate, is be confident in your skills, treat your patients appropriately. As long as you were able to treat them appropriately and get them to definitive care in a timely manner, cool, awesome. You don't need to bring in more people to monkey around with the situation. And I have to throw this in there too, because one of the advantages of my current job situation is the fact that I don't have to be a supervisor to be on a QRV. Literally, our department is QRV only. And again, for those of you who may use different nomenclature, a QRV around here is just a chase truck. It's a solo paramedic SUV that has all of the things in it that just can't transport. So I have the advantage of being in a place where I don't have to be up the chain to earn the spot on a QRV. And I have to say, there is no special magic about being a QRV paramedic. Like, previous places I've worked make it out like it's this, crazy wild thing that, is, there's so much responsibility and it's so different. And no, it's not. If you're using your clinical brain and treating your patients appropriately. The only difference is you might be by yourself on scene for a little while and have to manage a critical patient. That's it. That's really the only quote special part of it. So this whole putting some special voodoo around QRVs and chase trucks or whatever, it's just, it doesn't fucking matter. You're a paramedic with equipment in a vehicle that treats patients. Cool. That's all we are. And I'm not saying that to minimize. What I'm saying that to push back against this narrative of, oh, it's this, it's this special club that you're going to be a part of. No, it's not. It's fun. Don't get me wrong. I fucking love it. I am not shit talking it at all. But let's be honest, be intellectually honest with ourselves that there's nothing different. There's no special skill set, no special certification. If you are a competent and confident paramedic who treats your patients well, there's no difference. I try as much as possible when I am asked to respond as backup, even if it's an ALS transport unit. I do my best to not walk in with that chip on my shoulder, to walk in and treat them all as peers, because we are. Just because we may have different certifications, or may have a slightly different job title, doesn't mean I'm any better or more special or more holy or what the fuck ever than the other people I'm responding with. Anyway, I know it's kind of a side tangent, but when you were the one who was being called for help, don't be a douche, and don't come in and try and take over the call. That's another pet peeve of mine, and a lot of reasons why I at various places don't call for backup is because I don't need someone to butt heads with on a call. Now, I've been lucky that the vast majority of my direct supervisors that I've worked with over the years have been very hands-off, easygoing, easy to get along with people, and haven't butted heads with them, at least not on calls. But we all know those people that when they show up as backup, they make a call significantly more difficult than it needs to be, and that's not fair for anybody. So I generally try to avoid asking them for help unless I absolutely need it. And that's the thing, is ultimately, what does your patient need? Does your patient need help? Cool. Then it doesn't matter. If you're irritated with the person that shows up, well, work it out, sort it out. You need the extra hands. Get the extra hands, pony up, stay in charge, fight for your position, for not in an egotistical way, but if you know that the person who's coming to be your backup is going to be difficult, then stand your ground. Say, hey, I have been here. I know what's going on. Here's the deal. Unless you have some significant other input to divert us a different way, this is what we're doing. I just need extra hands and extra help. Cool. Easy peasy. Don't be hard to work with. So anyway, as I said at the very beginning, and I will reiterate it again, always follow your local protocols, policies, and procedures. Anything discussed here is purely my opinion and should not be taken as legal authority or anything. It's just some stuff I feel like we need to talk about, and we need to have a general understanding about, regardless of where we are and what kind of environment we work in. That's all I got for you guys. Be safe. I'll talk to you next time. Bye-bye.